Hello, my name is Sharon Terry, and I'm President and CEO of Genetic Alliance. Genetic Alliance is an umbrella group, a network of about 10,000 organizations interested in health, and of these, about 1,200 are disease or condition-specific groups doing advocacy and support. I'm going to talk to you about CENA, which is the Community Engaged Network for All. This is part of something called PIER, which is the National Patient-Centered Clinical Research Network, a very large undertaking by the U.S. government involving lots and lots of organizations across the United States, 29 of them to be exact. 11 of them are something called CDRNs, Clinical Data Research Networks, and these range from Harvard and Vanderbilt universities to foundations like the Kaiser Foundation Research Institute, and they're largely organizations, groups of hospitals, clinics working with clinical data. They're also representative of many diseases, common diseases as well as rare, and you can see some of them on this slide right here. In addition to the 11 CDRN, there are 18 PPRN, Patient-Powered Research Networks, and these are essentially networks of patients centered on individuals, organizations that have diseases, both common and rare. And here's a slide of them. The second slide of them, you can see halfway down our organization, Genetic Alliance, which is running CENA. I'm the PI, which means Principal Investigator. And under the condition column, you can see all of the conditions represented in our project. So many conditions, some rare, some common, all in CENA. CENA has these organizations working with us. You can see the names of them here. I won't go through them all, but each one of these organizations represents a number of individuals, anywhere from a small number of 100 or so to some representing 50,000 or more with these conditions. This allows these patients, these people who have the conditions, to be represented by these organizations in CENA, and CENA itself then is a network within the network called PIER. We're facing a problem and we're trying to solve it, and that is that fewer than 5% of people participate in clinical trials. This is dismally low, and we're losing a lot not to have the other 95% involved. Building large enough groups for studies is difficult. These studies need people, and they need people to participate in them in large numbers so that diseases and conditions can be better understood. These diseases are poorly understood at this point. We don't understand the ramifications of the disease sometimes. We certainly don't understand the progression, and very often we don't understand what would solve or prevent or treat the disease. And in all of this, we're missing our greatest resource, which are people and their health data. Sometimes it's said to us that, in fact, it's like trying to find a needle in a haystack looking for somebody for a clinical trial or somebody with a certain attribute of a certain disease. And we instead say the haystack is made out of needles. All of us, every single one of us is important. Every one of us will participate and share when we're given the right tools in the right situation. We know we have the right safeguards, and we know we can trust those who have our information. Every one of us is important for the puzzle. If one of us stays out of the puzzle, we will not have a complete puzzle. We will not understand the disease, its progression. We won't understand how to solve or treat the disease. We've looked over the years at a shift, and we've seen it very clearly in our culture. All of us know that our parents and our grandparents dealt with materials. They were working in steel or paper or iron. They were working with stuff that could run out. It was scarce. It had to be hierarchically controlled in a linear way because we had to manage it. We're now on this right-hand side of this slide, information age. We've seen it everywhere. We've seen it in music. We've seen it in publishing. We've seen it everywhere we can go. Open, abundant, it's information that's being parlayed, lots of information networks, lots of information services. It's a very organic way of moving. It is not linear, and it can be win-win. No one has to lose because there's plenty of information for all. We've also seen in lots of sciences for decades and centuries citizens being involved. So, for example, the Audubon Society every year has a bird count, and the bird count is done by ordinary people. We've seen that in physics. We've seen it in astronomy and entomology, the study of insects, where people make discoveries, people work on the science. We don't see that much in biomedical research in medicine and the research associated with it. And we want to see, how do we actually make that participatory too? How do we make people be involved, feel involved? People hold the keys. How about they also participate in solving the puzzles? Let's have the people bring this information together so that we can get an understanding of disease and health, understand the continuum from health to disease, and also understand that if we did this, we would probably lower costs, certainly in the recruitment side of clinical trials, but even in the discovery portions. Lots of groups exist to help us do this. We know that many of these groups are aggregating information. We've seen groups come together under one umbrella or another for a disease, or under umbrellas that are more general. This helps people to share their information, to share their experiences, but we also want to make this safe, secure, and very logical, and that's what we're doing in CENA. We have also seen a rise of these personal data self-tracking tools. So we can put in our pocket something that tracks our steps or our bike ride. We can step on a scale that transmits our weight and our body fat content to another device and does some analysis with it. So we've begun more and more to be able to understand our environment, our own health status through tracking devices. But in all of this, privacy is important. We've also seen that. It's been recent times of things like the NSA and Facebook using our data, people not being comfortable unless they know what's happening. And in this study by the late Alan Weston, which he did for the Institute of Medicine, he studied the conditions under which the public is willing to have their data used for health research. So spot on the topic that we're talking about. If you look at this curve, 1.5% of people say it's okay for researchers to use my health data without my consent at all. And 16.5% over there in the red on the right-hand side would not want researchers to contact me or use my data under any circumstance. What we do see, of course, is that most people fall in the middle of this graph. And they want some granularity here. They want, maybe you'll ask me about this and maybe about that and sometimes this. And this starts to make researchers crazy. Not only do they have to do the important research of the condition and all the things around the condition, the biology, the pathology, but they also then feel like they have to do this complex kind of ascertainment of people's consent. We're saying no, actually there are tools now, just like on the net I can use tools that help me to get to a rare book in a garage in Ireland. I can get also data from people in a safe and secure manner according to their wishes, and that's what CENA is allowing. I can respect everyone in this whole spectrum. So for this tool for engagement that CENA uses is called the Platform for Engaging Everyone Responsibly. The Platform for Engaging Everyone Responsibly we can refer to as PIER, which I will do throughout the rest of this presentation. And this tool gives us a dashboard. And you can see little words lighting up here: allow, ask me, and deny, and edit. So allow, meaning I will allow whatever it is that's going to happen, and I'll talk about that in a second. Ask me is a kind of maybe. I will want to do it maybe, and maybe not, so ask me. And deny means I don't want to do it. And so we have both a yes and a no, but unlike many systems, instead of opt-in or opt-out, we have an ask me. And very important to this system is the fact that you could edit these at any time, because my preferences might change over time. I might, in fact, have a child born that seems healthy, and in a year or two in, looks like he may be exhibiting some symptoms of some condition. Or an undiagnosed condition, or a spectrum disorder. And so I may want to change my mind and share information. Or I might, in fact, be the legal guardian for my parent who's elderly, and that person has Alzheimer's disease, and I think that that information should be part of a registry or part of a study so that we learn more about the condition. It's important to look at what are we talking about allowing or denying or asking. And if we look at the three different buckets here, the first is to discover. Discover and view my anonymous information. I can also click for more details if I want to. So the type of information would be that my anonymous information would be discovered. It would be discovered that my mother is in her 80s, lives in Connecticut, and it has Alzheimer's disease. That's all. It would be that we could make her discoverable for research. In the second column, dedicated to that specific condition, or we have foundations supporting other conditions. Of course, I could have Alzheimer's and psoriasis, or heart disease and diabetes. We can look at medical researchers of different kinds studying different things, and data analysis platforms, including our dear PIER, the Patient-Centered Outcomes Research Network. We also can put here other future pilots or things that could be interesting. For example, newborns might be sequenced one day, and we'll want to give parents the permission, the opportunity to decide who gets that information. And again, we could edit these at any time. That could be pretty complicated to set all those settings, and so what we've done is we've given the participant, the person who comes to this portal, guides. In this case, you're looking at guides from Southern Connecticut who have sickle cell disease or who have a loved one with sickle cell disease. And so these individuals are telling you a little bit of their story, enough that you get a sense of who they are. You can click on them, listen to a video by them, and ultimately look at their dashboard. If I go to another campaign here, I'm looking at people who have either a loved one with pulmonary fibrosis or who themselves have pulmonary fibrosis. And I can see how they feel about sharing their information. So Sarah here is a little bit toward the green out of the middle section, and so she's feeling somewhat lower privacy concerns and higher interest in sharing. Dr. Fuentes is moving a little bit toward the not sharing, or at least being more cautious, maybe the ask me area. And if we look at George here, who's a 70-year-old sports journalist, has lived in the public eye all his life, he's way up here in the green, very liberal, very much in a sharing mode about his information. Or I can create my preferences manually. So if I click on any one of these and select them as my guide, I would listen to a video by them and see what they thought. I also can look at an activity log at any time, which will allow me to see what has happened, who has come, who has looked, and I can set these settings for any user, for myself, for people I have the permission to set settings for, to make preferences for. This can all go to my smartphone or to my tablet in order that I might, for example, get a research opportunity alert saying, here's a study you might be interested in. I could click links within this to get more information, and I can consent, I can decline, or I can snooze because I want to look at this later. So let's look at another community. Here we have a breast cancer community. Here's a couple of the guides from that community, Andrea and Ruth. I can listen to either of their videos and look at their preferences, what they set as their sharing screens. In this case, we'll look at Andrea. And what we see, first of all, is that Andrea has set by default a moderate privacy concern screen. That moderate privacy concern screen tells me what she thinks about as ideal privacy settings for someone with a moderate privacy concern. We also ask each guide, though, to say, now, Andrea, if someone came to you who had lower privacy concerns, what would you say? And I could click on that tab, or greater privacy concerns, and I could click on that tab. In any case, I could go back if I wanted to see Ruth, for example, and instead, or in addition to. I could also customize. I could click that and change any of these, like I like these, but I'm going to say allow for this organization serving my condition. And if I click next, it will verify all of this for me and tell me exactly what I've chosen. Okay, so I've set my privacy settings. I've set who has access to my information, what I'm going to share. And now what is it that will be shared? Well, we're collecting information. So we're collecting self-reported information, which is very important in this thing called PIER, patient-centered outcomes research. It's patient-centered. It means I have to tell you something about myself, my life, my health, my environment. And so we're asking questions that are important for that. In this section, we'll see things that we're calling common data elements. Those are common questions we want to ask across all groups. We want to ask them in the same way. So if we want to ask, do you smoke? We don't want to just say, do you smoke? Because that might mean, did you ever smoke? How much did you smoke? When did you stop smoking? And so we will ask those questions in a very structured way. Now that could be pretty boring and tedious. And so what we do is gamify these questions and their answers. I get to see, how do I compare to others? How do I contrast with others? And so, for example, in the question I'm showing here, I feel well informed about my health. I answer that question and put a dot on this continuum between not at all and extremely and see, wow, 61% of people felt less informed than me, and 33% feel more informed than me. 39% feel more informed than me. I can also say I don't know, and I can skip the question. Or if I look at one or more of both of my parents smoked during my childhood, childhood or adolescence, if I say always, which I did, 26% say always, 25% say sometimes, and 48% say never. And so I'm getting feedback instantly on what I've answered so that I know how I compare to others. I can also go back at any time and look at my answers. I can also change them. They are time-stamped, and so they're saved in the system, and that's recorded so you can see how I changed them. And I can also look at my progress at any time. We even give little badges for numbers of questions answered. We get about 200 questions answered in each sitting by each individual. That's pretty impressive because people get very engaged in seeing how they compare and contrast with others. So where does this live? It lives on the website of the organization. It lives right on the website, looking very much like the organization because it's colored in their colors and their logo and their motif. In this case right here, this is a little badge. This badge can be put on a third-party website or blog or Facebook. So in other words, this could appear on a local hospital or even a hospital, you know, in another country. It could appear on a community bulletin board. It could appear on a church website. It can appear anywhere that you might recruit individuals with this condition. And if you click this, it will take you to the website. The portal itself, PIER, lives right inside the website. And you can see that PIER looks just like the group's logo and font and call to action headlines, et cetera, are all the same as the group has always used. The group itself, the organization, has selected a personality, these guides, who allow me to feel comfortable because they're trusted people, they're key community members. These buttons can be customized and be flexible so the group has some sense of how they should sound and what they should look like. We always put our privacy policy and terms of use on the site so that they're quite transparent. And finally, this referral code is a very cool thing. If I give out brochures at a health fair this afternoon, and later I can look and see with how many people entered the referral code from those brochures right here, so I know whether or not that was effective outreach. I also can have a referral code come in off the badge. I can also have a referral code come in off of email. There's many ways I can use the referral codes. And so PIER is completely customizable. It is the way that we want to give individuals the tools to set their own preferences, to decide who sees their data, how their data is used, to see when they want to share it, and to be able to determine data access. You can see by this slide lots of different ways for it to look and feel, very local, very community-based, but part of this national network, this network of people around the U.S. and beyond that are looking at how do we share data safely, how do we put health data together to paint the picture of health and disease. Finally, I think that this is an ultimate example of this great saying by a Native American activist, nothing about us without us. This us is all of us. It's people with disease, it's people without disease, it's clinicians, it's researchers, it's policymakers. We are bringing us all together ultimately to start to tell ourselves, how are we going to move forward? How are we going to get to solutions, therapies, interventions, things that will ameliorate disease? Ultimately, how are we going to alleviate the suffering of our loved ones together? Thank you.